Today we want to look at what can we do, not only to understand and measure and track stigma, but how to effectively address it. And if there's one thing, one key question that we can perhaps address is which actions or how can we act to really impact on reducing stigma affecting key populations at scale. In terms of the a few logistics announcement. Maybe if we can go to that slide. Yes, so please, on this on the screen you see you can choose your preferred languages. So click on the translation interpretation icon at the bottom of the screen to choose English, French, Portuguese, Russian, and Spanish. And for questions, please use the Q&A box at the bottom of your screen to ask the questions. So I think we can move back to the agenda. Yes. So what we'll do in the next hour is basically look at the evidence first, then go into guidance and practice, hear country practice examples in breakout sessions, and then takeaways from the session and the closure. So the objectives of this session are twofold. We have a slide on this. So first of all, understand the evidence and guidance to address stigma in key population programs. And secondly, really how to understand how countries are implementing stigma reduction programs and what can we do to actually influence and reduce stigma in a way that impacts key populations' experience at scale. First, I'd like to hand over to Anne Stangl, who will actually provide us an evidence overview and works with this US CDC and will give us a presentation on evidence-based interventions to address stigma against key populations. Over to you, Anne.
Sure. Thank you so much, Clemens. And good morning, good afternoon, and good evening, everyone. I'm so pleased to be here with you all today to share an overview of evidence-based interventions to inform or to address stigma against key populations. Next slide. So I would like to begin today by discussing why it's so important to address key population stigma and discrimination. Next slide. First and foremost, the experience of stigma is an infringement on our human right to live a life free from discrimination, as enshrined in the Universal Declaration of Human Rights. Next slide. Secondly, evidence is mounting across the HIV prevention and treatment cascades, demonstrating how stigma, discrimination, and violence are impeding the achievement of 95-95-95 targets among key populations. This slide highlights a few of these studies. For example, under combination prevention, experienced stigma has been associated with lower rates of condom use for transgender people in the Dominican Republic. Under the first 95, a study found that stigma among men who have sex with men and female sex workers in Kenya led to higher odds of reporting delay or avoidance of counseling and testing. From a policy perspective, we can see that laws can either encourage or impede knowledge of HIV status. For example, Kavanaugh and colleagues found that globally, gender-based violence laws were associated with higher knowledge of HIV status. Conversely, sex work, drug use, and same-sex criminalization were all associated with lower knowledge of HIV status. Under the second 95, a systematic review of studies with female sex workers in sub-Saharan Africa revealed a strong association between stigma and discrimination and poor linkage to care, ART, and retention in care. And globally, lower access to HIV treatment for MSM is associated with criminalization of same-sex behavior. Under the third 95, higher internalized stigma scores have been significantly associated with missing an antiretroviral treatment dose, among female sex workers in the Dominican Republic, and with poor viral suppression among people living with HIV in Zambia and South Africa. And among trans women in Brazil, lifetime experiences of sexual violence were found to be associated with subsequent reduced likelihood of retention in HIV care and viral suppression. Next slide. According to the UNAIDS Global AIDS Strategy, to reach the 95-95-95 targets, it's critical for countries to achieve the 10-10-10 societal enabler targets. Specifically, countries are striving to achieve less than 10% of people living with HIV and key populations experiencing stigma, and discrimination, less than 10% of people living with HIV, women and girls, and key populations experiencing gender inequalities and gender-based violence, and less than 10% of countries having punitive laws and policies. Next slide. So now that we're clear on why it's critical to eliminate key population stigma and discrimination and what the societal enabler targets are, I want to share with you a tool called the Health Stigma and Discrimination Framework. The framework, together with existing data on HIV and key population stigma and discrimination in your country context, can be used to guide discussions with key stakeholders to determine where efforts need to be focused. I'll spend a few minutes on this slide to walk you through the stigmatization process, introduce some key terminology, and discuss how you can use the framework. The framework articulates the stigmatization process as it unfolds across the socio-ecological spectrum in the context of health. The process can be broken down into a series of constituent domains, including drivers and facilitators, stigma marking, and stigma manifestations, which influence a range of outcomes among affected populations, as well as organizations and institutions that ultimately impact health and society. The first domain refers to factors that drive or facilitate health-related stigma. Drivers vary by health condition, but they're conceptualized as inherently negative. They can range from fear of infection through casual contact for communicable diseases to concerns about productivity due to poor health for chronic conditions to social judgment and blame. Facilitators, however, may be positive or negative influences. So, for example, the presence or absence of protective supplies in a health facility can minimize or exacerbate stigmatizing avoidance behaviors towards populations with infectious diseases by healthcare workers. Drivers and facilitators determine whether stigma marking occurs, in which a stigma is applied to people or groups related to either a specific health condition or other perceived difference, such as race, class, gender, sexual orientation, or occupation. Intersecting or intersectional stigma occurs when people are marked with multiple stigmas. And once a stigma is applied, it manifests in a range of stigma experiences and practices. So stigma experiences can include experienced discrimination, which refers to stigmatizing actions or omissions that are prohibited under international human rights law. For example, losing housing because of one's HIV status. An experienced stigma refers to stigmatizing actions that fall outside the purview of international human rights law, such as double gloving or gossip. Another stigma experience is internalized or self-stigma, which is defined as a stigmatized group member's own adoption of negative societal beliefs and feelings, as well as the social devaluation associated with their stigmatized status. Perceived stigma, which refers to perceptions about how stigmatized groups are treated in a given context, and anticipated stigma, which refers to expectations of bias being perpetrated by others if their health condition becomes known, are also classified as stigma experiences in the framework. And lastly, secondary stigma, which refers to the experience of stigma by family or friends of members of stigmatized groups, is included under stigma experiences. So stigma practices, on the other hand, include stereotypes, prejudice, stigmatizing behavior, and discriminatory actions. The framework considers stereotypes and prejudice as both drivers and manifestations, as they both fuel and are reinforced by the stigmatization process. So these manifestations go on to influence several outcomes for affected populations, including access to justice, access to and acceptability of healthcare services, uptake of testing, adherence to treatment, resilience or the power to challenge stigma, and advocacy. They also influence outcomes for organizations and institutions, including laws and policies, the availability and quality of health services, law enforcement practices, and social protection. So now let's get back to how you can use the health stigma and discrimination framework to plan programming to reduce and mitigate key population stigma and discrimination. In terms of where to intervene, ideally, we want to stop stigma marking from occurring. So interventions often focus on the drivers and facilitators of stigma. While we would like to prevent stigma from being applied, we also need to be prepared to deal with the manifestations of stigma. This could include psychosocial support for people living with a specific health condition or legal aid to cope with discrimination. It could also include training for healthcare providers or police to overcome stereotypes and discriminatory attitudes, or the development of new laws or policies to protect against discrimination. Next. So as we don't have time to go into more detail today, for those who would like to learn more, I recommend three guidance documents. The first, which you see here, is the 2020 evidence guidance launched by UNAIDS. Next slide. And the tools you see here, which were launched last September by the Global Partnership, are also excellent resources for you. So the links to these documents are included in the slide. Next slide. So now let's review some of the evidence-based or evidence-informed strategies available for eliminating KP stigma and discrimination and achieving the 10-10-10 targets. So as I mentioned earlier, it's important to include interventions to address both the drivers and facilitators of KP stigma and the manifestations of KP stigma and discrimination. In the next few slides, we will review examples of evidence-based or evidence-informed approaches to achieve each of the 10s, organized by whether they address the drivers or the manifestations. And links to relevant resources are included in the slides. Next, please. So for the first 10, approaches to address the drivers and facilitators of KP stigma could include KP-led training for health facility staff on KP competent care and stigma-free service provision, KP-led training of police on gender sensitivity, HIV, and harm reduction, differentiated service delivery models that minimize stigma and discrimination, such as KP-led drop-in centers, online interventions, and so on, training for peers to provide psychological first aid to those in crisis, and implementing U=U campaigns. Approaches to address the manifestations of KP stigma and discrimination could include psychosocial support for KPs who experience stigma and discrimination, strengthening referral networks, routine implementation of community-led monitoring and the PLHIV Stigma Index 2.0, also pivoting to a more universal offer of PrEP in high stigma or criminalization areas, moving away from invasive risk screeners to a conversational approach that does not have to identify someone as a key population, and training case managers or other health providers to identify and refer those with mental health issues. Next slide. For the second 10, approaches to address the drivers and facilitators of KP stigma to reduce gender-based violence and inequalities include implementing evidence-based solutions to reduce violence and shift harmful norms, understanding the burden, causes, effects, and circumstances around violence through high-quality data, KP-led advocacy for policies and procedures that prioritize safeguarding KPs against violence, and work with law enforcement to reduce violence against KPs and program implementers. Approaches to address the manifestations of stigma to reduce gender-based violence and inequalities include training providers, police, and other staff on violence-specific adaptations to psychological first aid and integrating these adaptations into PrEP and index testing, ensuring timely availability and access to support services, including post-exposure prophylaxis within 72 hours of exposure, and psychological and psychological support, and ensuring and widely disseminating safe reporting structures, such as the National Crisis Response Systems and National Reporting Mechanisms for Human Rights Violations. Next slide. So for the third 10, approaches to address the drivers and facilitators of KP stigma to reduce or remove punitive laws and policies include community-led evidence-based advocacy with national stakeholders utilizing CLM and stigma index data, routine implementation of the Stigma Index 2.0, the National Commitments and Policy Instrument, and legal environment assessments, developing a national strategy and operational plan for eliminating stigma and discrimination, implementing Know Your Rights campaigns, and routinely informing and sensitizing duty bearers on the legal, health, and human rights aspects of HIV, on relevant national laws, and on the implications for enforcement, investigations, and court proceedings. Approaches to address the manifestations of punitive laws and policies for KP include providing legal information and referrals, providing legal advice and representation, integrating paralegals into health facilities to provide on-site guidance and support for key populations and people living with HIV, strategic litigation, alternative forms of dispute resolution, and policy reform to shift the health and human rights environment for KPs. Next slide. So in closing, I would just like to share a few considerations for ensuring the safety and security of key populations. As you know, KP-led organizations, especially in hostile environments, experience chronic violence and other human rights violations, which negatively affects all aspects of the HIV program cycle. Ensuring data security by all organizations collecting and managing KP data is critical. Based on the context and situation, consider whether service delivery adaptations are needed. This could include expanding virtual or telehealth services, extended dispensing intervals and expanded multi-month dispensing, home delivery services, increased use of self-testing, and increased provision of mental health and psychosocial support to affected program participants and staff. Adaptations may also include the temporary suspension of some interventions or activities, such as group outreach or moonlight testing. And lastly, I encourage you to utilize available rapid response mechanisms when needed. So next slide, and thank you so much for your attention. I'm really happy to answer any questions you have in the chat. Back to you, Clemens.
Thank you so much, Anne, for this very concise and excellent overview of the evidence and really on what can be done to address stigma effectively, including as part of prevention programs. There's a number of strong links to prevention where actually implementation of key population prevention programs can really make a significant contribution to addressing stigma. We'll go now from the evidence overview to a brief synthesis of the available guidance, and I'll call on Dottie Ogutu from GMP Plus, Global Partnership of People Living with HIV, for providing us an overview on available guidance. Dottie, over to you.
Thank you, Clemens. I just want to make a disclaimer before I continue, is that because of time limitations, we will not be able to give you a deep dive onto what Global Partnership does, but I'll focus more on the guidance. But the rest of the information about Global Partnership is available on your slides. Yeah, so next slide, please. Yeah, so I'll pick up where Anne left off, and you'll see that she very clearly mentioned some of these guidance tools in her presentation. So if you click on this on your presentations, you'll actually lead you to the documents and you can download them. But so let me get a chance to briefly explain what are some of these guidance tools. So next slide, please. Okay, yes. So I mean, as part of the technical support provided by the Global Partnership to the countries, there are several guidance documents, as you've seen, and these have been developed in the Global Partnership mainly to help identify and plan in implementation, monitoring, and evaluation of evidence-based and evidence-informed programs that are designed for addressing stigma and discrimination in the 6 settings of Global Partnership. So the new guidance that you see here is a companion of the 2019 and the 2019 rights-based M&E guide and the 2020 evidence guide. So these documents really work hand in hand together, and it's specifically focusing on monitoring and evaluating programs in the 6 settings. So the new guidance supports program implementers and managers at government agencies, NGOs, civil society, and community-based organizations to understand the outputs of their programs and the outcomes of their programs that they're implementing to mitigate stigma and discrimination. And it also helps in improving and scaling up of those specific programs. Next. Yeah. So but I would like to make this disclaimer is that the new M&E guide, so that first document that I just shared, is a practical resource. So in order to understand how this works, you really should be able to to get the detailed explanation that is in the two previous guidance documents, the 2019 and the 2020 guidance documents. I know there seem to be a lot of guidance documents there, but they cover different elements of how you can, one gives you a practical guide and the other one gives you the evidence guide. So the documents are really complementary in how you're supposed to apply them in, in your M&E work. Next slide. Yeah, so a little bit more, and I'm going to focus on this a little bit more on the new M&E guidance, which is designed and it is aligned in harmonization around the 6 settings of the global partnership. So the 6 settings being community, workplace, education, healthcare, justice, and emergency or humanitarian settings. And the context here is aligned with the political declaration, and did mention the political declaration that was adopted at the United Nations high-level meeting in June in 2021. And this is where the societal enablers come in. And so this new guidance aligns each of the settings identified there with the societal enablers, and the implementing organizations are able to select their own output and outcome indicators in this case to understand how their programs are operating and how they could be better improved. And for more, as an example, you can think around how you collect the data in some of the programs that you're running at national level, your program outcomes for Global Fund and PEPFAR, and you can use that to report on your global AIDS monitoring processes. Next slide. So if we look at this, and then there's this other guide, which is the practical guide. I am aware of my time, which is very limited. This gives you a way to how you can apply the best practices when you're addressing stigma and discrimination. So they might not be specifically talking to key population, but it's a practical guide that can be applied whether you're working with key populations, you're working with women, you're working with young girls, you're working with children. It's a practical guide that can be used to highlight best approaches, and you can use that as a stock taking and a knowledge generating process to understand how you can apply your implementation in a practical manner. And then, and you're able to understand the 3 simple steps. If you move on to the next slide, please. Yeah, so this 3, it's intended for national, international partners, civil society, duty bearers, law and policy makers, duty bearers in the different settings that I did mention. And if you're able to understand how HIV-related stigma and discrimination do harm, the process of stigmatization, which I think Anna's clearly elaborated in her presentation, and how it manifests and the repercussions of it. So if you're able to familiarize yourself with the concepts around that, and reviewing the 2020 guide, I mean, all these guidance documents really work hand in hand with each other in terms of being able to guide you in terms of your implementation, your practical guide, your advocate's guide. And I will move on to my last slide, which is around the work. Yes. Yeah. And additional tools and campaigns that are run under the global partnership. We have our guides and our checklist there. We have our Not a Criminal campaign, which is really the fundamental or the basis of the Decrim campaign that we are running as GNP Plus, as the community advocate lead and the global partnership, and other campaigns that we are running around zero discrimination, HIV discrimination, and the More Than campaign around the global partnership. Please feel free to reach out to us. We have our contact information in the slides, and we'll be more than happy to talk to you and give you more information about how we can engage under the global partnership, which some of your countries are part of. Thank you.
Thank you, Dorothy, for this great overview on the guidance. And Dorothy represents the Global Partnership for Action to Eliminate All Forms of HIV-related Stigma and Discrimination. And this webinar is really a collaboration between the Global Prevention Coalition and the Global Partnership, showing that, you know, the aspects that we're discussing here need to be advanced through both initiatives. With that, over to Erika Spielmann from WHO, an active member of the Global Prevention Coalition, for a brief presentation on stigma and discrimination in healthcare settings.
Great. Thanks so much, Clemence. Thanks everyone for being here this afternoon or morning or evening. I will be talking today about stigma and discrimination in the healthcare setting. Can you go ahead and advance to the next slide? And what WHO brings to the table there. So to start with the global partnership that Dottie has been speaking of, WHO is a member of this, and our role really there is the WHO leadership in healthcare settings. So she had mentioned the 5 different settings. WHO focuses again on the healthcare settings. So to start off, to let you know, within our the HIV team, our department is actually HIV, STIs, and hepatitis. So even though we are we need to keep a broad view on these 3 elements, today we will be speaking more specifically about HIV. So in our global health sector strategy, we have targets for 2025 and 2030 related to stigma and discrimination. Next slide, please. So in addition to the global health sector strategy, the other guideline, and I would like to point your attention to, is the consolidated guidelines for care for key populations. So this is a very rich document. It's focused. It breaks out according to different key populations, actionable drivers, and this is some good practice guidance statements that are highlighted regarding stigma and discrimination. It talks about human rights, the importance of engaging human rights and laws. It talks about importance of collaborating with all level communities, to policymakers, and the monitoring and evaluation that goes along with that. We talk about healthcare services, making sure they're accessible and acceptable and ethical. We talk about training of healthcare providers, and this is, goes all the way from pre-service, in-service, recurring trainings to educate not only about stigma and discrimination, internal stigma, and to promote non-discriminatory behavior, but also to talk about key populations specific, which Anne had mentioned in her presentation as well. And we talk about services, making sure that they're safe and protected. Next slide, please. This is a schematic from the same guideline that I was just referring to. Again, a very rich guideline talking about the multi-interventions for key populations and the syndemics. So on the left-hand side, you'll see some evidence around why it's so important to include STIs as well. But as Anne had already referred to, is there stigma? And then, of course, we need to think about all the different elements and the intersectionality that comes with that. So yes, we need to consider laws and policies in the healthcare setting. We need to consider violence, other human rights, unemployment, poverty, gender, race, disability. All of these obviously contribute to the reduced access to prevention, testing, and treatment services. And in addition to that, we need to consider biological and social factors. If we work with one without the other, our success will probably not be as great. So I really like this schematic. Again, you can find it in the key population guideline, the WHO key population guideline. Next, please. So in addition to those two documents I've highlighted, I wanted to just bring your attention to some of the other documents that WHO has. In the middle there, you'll see integration of mental health and HIV interventions. Fantastic. You know, again, we need to be thinking cross-sectionally, interdisciplinary. There's some global competencies. On the right-hand side, that's to the, also has an HIV particular specific module. So just, you'll get these slides. You can go ahead and tap into those and see more where you can focus your efforts. Next slide, please. In addition, leveraging the stigma reduction power of viral suppression, U equals U. This was also mentioned by Anne, a really great document that we can use to leverage the stigma reduction. I know my time is up, so I'll peruse through. Next slide, please. Almost done. And then finally, coming hopefully July or so is a technical brief that WHO will be developing. We're trying to characterize stigma and discrimination and change the meaning, not the meaning, but the thought behind it as negative to positive. So our working title is Providing Good Quality Healthcare by Ensuring Dignity, Equity, Inclusion, and Reducing HIV-Related Stigma. And this brief is really to make those interventions that Anne referred to more concrete. So we're going to be talking about the principles and components of that happening and giving really good case examples and practical examples that could be adapted to different settings and synergizing across sectors, as I've mentioned. So stay tuned for that to come. Thanks, everyone. And if you have any questions or feedback or want to get in contact, please do so.
Thank you so much, Erica. Great and concise overview on WHO stigma-related guidance in the context of healthcare services and settings. From here, we now go actually into country practice exchange and using a new modality for this key population community of practice sessions, we'll actually break into 3 different rooms. So in the main room, we will have an experience from Peru. In the breakout room 1, we will have an experience from Zimbabwe, and in breakout room 2, an experience from Jamaica. So please join one of the rooms. I think we'll give ourselves about 30 seconds to do that and then start the discussions. And there will be specific moderators in your breakout rooms. We can proceed in the main room. Great, Karabo. So without further ado, I'll hand over to Mara Sumudio and Angela Villon from Peru to share their country experience and insights from Peru. So over to you, Farah and Angela.
Hola, buenos días. ¿Me pueden ver?
Todo bien, buenos días.
¿Mi cámara está desactivada? ¿Me la pueden activar?
La cámara no es activa, no es activada.
Bueno, entonces empezaré sin cámara. Bueno, en el Perú siempre ha habido mafias, siempre han existido policías, malos elementos policiales que han cobrado cupos, que se han organizado para delinquir, para hacernos violaciones sexuales sistemáticas. También habían mafias de malos peruanos que se dedicaban al cobro de cupos y esto sumado a las leyes criminalizantes que tenemos dentro del Código Penal, como por ejemplo la 179, que es de favorecimiento a la prostitución, en un país donde la prostitución no es delito. Esta ley es tirada de los pelos porque siempre ha sido como utilizada como un instrumento para el chantaje, para la extorsión, para las violaciones sexuales. Y no solamente esta ley que nos criminaliza, sino algunas otras leyes, como por ejemplo el de trata, donde especifica claramente todas las condiciones para que una persona sea víctima de trata. Sin embargo, también menciona la palabra prostitución, cuando los reales delitos es la trata de personas para explotación sexual, entre otros, ¿no? Igual sucede con el rufianismo. Entonces, nosotros tenemos ya las mafias desde antes, y esto ha permitido que el 99.9% de las intervenciones policiales sean para el chantaje y la extorsión y para la vulneración de derechos humanos. La segunda, por favor, diapositiva. El Perú tiene un número creciente y alarmante de homicidios y desapariciones, de secuestros, de parte de la mafia. Este podría hacer una historia, ¿no? Que en el 2019 ingresaron personas que eran mandados por las mafias para que hicieran un mapeo y una investigación de las plazas, entre comillas, que son los lugares de trabajo sexual. Nosotras no teníamos muy claro qué era lo que estaba pasando, pero sí vimos cómo es que gente extranjera muy bien parecida empezaban a rondar por los lugares de trabajo sexual y se acercaban a los mafiosos peruanos, ¿no? A identificarlos. De repente, en el 2020 empezaron a asesinarlos, a asesinar a los mafiosos peruanos y a desplazarlos de los lugares de trabajo sexual de donde ellos ya venían cobrando cupo. Los empezaron a desplazar las mafias extranjeras. En octubre del 2020, después de la pandemia, nosotros recibimos un primer mensaje de presentación de las mafias de malos extranjeros que llegaron al Perú a delinquir. Ellos se presentaban como una organización que iban a hacer, iban a ocupar las plazas y que iban a recaudar fondos para hacer beneficios allá en su país. O sea, se presentaban como si fueran buenas personas, ¿no? Sin embargo, hubo una resistencia por parte de las trabajadoras sexuales peruanas de dejar estas plazas, y entonces empezó a haber mucha violencia. Tanto así que en febrero del 2022, asesinaron a 2 ecuatorianas en el centro de Lima que se rehusaron a pagar estas plazas. A partir de ahí hubo recién un interés del gobierno de ocuparse de este tema, porque a pesar de que durante todo el tiempo nosotras vinimos denunciando este problema, ellos nunca nos hicieron caso y dejaron que las mafias se pudieran incrustar dentro de la ciudad de Lima. Es más, en estos mensajes ellos se presentaban y presentaban inclusive la estrategia que iban a utilizar, como por ejemplo que esto era como un plan piloto, esto de apropiarse de las plazas y del cobro de cupos, porque de ser así, este plan piloto y de llevarse a cabo bien, se iba a extender a las regiones. Y esto se denunció y se dijo, pero se hizo caso omiso. En febrero del 2023 fue un inicio de una violencia extrema, porque si bien nosotras habíamos con las mafias peruanas sufrido de violencia, como por ejemplo cortes en la cara, o cortes en un seno, o cortes en un glúteo, nunca nos mataban. Y cuando empezaron a asesinar a las compañeras en el 2022, habían asesinado a gente víctimas de trata que ellos mismos habían traído. Sin embargo, en febrero del 2023 asesinaron de una manera tan violenta a nuestra compañera Rubí Ferrer y Priscila Aguado, pero ya con una cuestión de amedrentamiento que fue filmado, en el cual le propinaron 33 balas, y esto fue filmado y enviado a las redes del WhatsApp de ellas, entonces de ellas, pues, ¿no? Entonces nosotros lo recibimos, fue algo muy impresionante, de extrema violencia, y del cual nos causó mucho terror. El año 2022 lo cerramos con 35 desapariciones y 36 asesinatos. El 2023, que asesinaron a Rubí Ferrer y Priscila Aguado, cerramos con 41 desaparecidas y 32 asesinatos, ¿no? Las trabajadoras sexuales en estos momentos somos víctimas de violencia sexual, de torturas, asesinatos, secuestro, extorsión por parte de las mafias que han tomado el control, sobre todo de las calles céntricas de Lima y también en algunas regiones del país. Esos asesinatos se tienen ahora este modus operandi, esta estrategia que han traído de filmarlos y pasarlos a los contactos de las víctimas. Esto ha traído como resultado que las trabajadoras sexuales no podamos seguir ejerciendo el trabajo sexual de una manera segura. Ahora no solamente las víctimas de trata son las que pagan cupos, sino también las peruanas. Igual todo el mundo paga, hay diferentes mafias, tenemos inclusive los mellizos que se suman a mafias peruanas con extranjeras que se han asociado. Entonces, eso ha traído precariedad, el Estado no nos asiste, vivimos en lo que nosotras llamamos en una vulnerabilidad extrema porque estamos en un país machista, misógeno, judeocristiano, conservador, que no voltea a ver a las trabajadoras sexuales porque las considera ínfimas, y esto obviamente ha traído que se ponga en riesgo la adherencia al tratamiento antirretroviral de las personas que viven con VIH y que no se puedan acceder tampoco a los servicios relacionados con el VIH. Doy paso a mi compañera Farah.
Buenos días, buenos días. Sí, se me oye, ¿verdad? Se me oye, ¿verdad?
Buenos días. We
Sí,
can hear you.
eh, bueno, si es que seguimos con las diapositivas, a mí me toca ver la parte o exponer la parte de qué cosa hemos hecho frente a esta violencia de género que se vivió en el Perú, cómo la abordamos. Bueno, lo primero que iniciamos fue con reubicaciones temporales para las mujeres trans y cis trabajadoras sexuales que han sido amenazadas por estas mafias de cobro de cupos, estas mafias de extorsión, ¿no? Como una especie de respuesta, las pudimos reubicar. eh, Primero se creó una situación, una comisión, un comité de dos mujeres trans y una mujer cisgénero que eran las que aprobaban estas reubicaciones, ¿no? Debido a las solicitudes que ellas presentaban, y en menos de 24 horas se podía dar respuesta para poder trasladar a estas personas que habían sido amenazadas o que habían tenido cualquier situación de peligro frente a estos extorsionadores, pudiendo así trasladarlas a sus lugares de orígenes o donde ellas decidan que estaban seguras, pudiendo así salvar la vida de las mujeres trabajadoras sexuales en el momento, ¿no? En esta acción de emergencia. Otra de las acciones que tomamos fue dar respuesta a la seguridad alimentaria de las mujeres trans, puesto que el contexto de violencia no las permitía trabajar, ¿no? Estaban siendo extorsionadas, estaban siendo violentadas. Entonces las mujeres trans que viven del día a día del trabajo sexual no podían tener recursos para poder alimentarse. Es así que con el Programa Mundial de Alimentos, como con otras organizaciones, pudimos brindar ayuda. Se brindó asistencia alimentaria para 60 mujeres trans en situación de necesidad de alimentos, ¿no? Y junto con el fondo de asistencia alimentaria que se implementó, pudimos ayudar a 10 personas, 5 mujeres trans y 5 mujeres cisgénero, que se encontraban en situación de desamparo que no contaban, que no podían trabajar, ¿no? También se brindó acompañamiento legal para las víctimas. Hola. También pudimos dar acompañamiento legal a las mujeres trans, ¿no? Y cis que fueron amenazadas, ¿no? De la mano con organizaciones aliadas que trabajan el tema legal. Asimismo, pudimos crear alianzas con Defensa Pública y el Ministerio de Justicia y Derechos Humanos de Perú para que pueda brindar acompañamiento a las denuncias. También realizamos recojo de información para poder presentar documentación a la CIDH, ¿no? Para poder presentar la solicitud de audiencia temática a la Corte Interamericana de Derechos Humanos, ¿no? De la mano con Sinergia y de la Red LAC Trans, ¿no? Así como con ONUCIDA. Eh, También pudimos conectar, unir o hacer el lazo entre las organizaciones que defendían derechos humanos de las mujeres trans con los fondos, con las organizaciones que brindan recursos de ayuda inmediata para poder acceder a fondos o dinero que las pudiera apoyar o recursos para que puedan ellas salir de esta emergencia y puedan ayudar a la población trans que se encontraba en peligro en ese momento. Como mencioné, hicimos la solicitud a la Corte Interamericana de Derechos Humanos para poder tener la audiencia temática, ¿no? Luego, creamos un informe para poder evidenciar la situación de las mujeres trabajadoras sexuales en estos últimos años y cómo había surgido este estallido de violencia hacia las mujeres trans. Em, Siguiente diapositiva. En el siguiente, ajá. Acá podemos ver las acciones de incidencia que pudimos realizar, ¿no? Pues, hicimos acciones de incidencia frente a las plazas, frente a instituciones gubernamentales, con la finalidad de que puedan accionar y puedan investigar las muertes y dar seguimiento a las denuncias de las compañeras, ¿no? Y de las familiares que clamaban justicia por sus muertas. Eh, Siguiente diapositiva. Eh, Luego, acá también podemos ver cómo pudimos brindar asistencia alimentaria para las mujeres trans que se encontraban en situación de necesidad y poder dar respuesta inmediata hacia la comida, el alimento diario, ¿no? Eh, sí, podemos seguir. Eso fue con la ayuda de la OIM, ¿no? Y de otras organizaciones. Acá, esta son los números para poder seguir apoyando el fondo de emergencia. Eh, Debemos de tener en cuenta de que la situación no ha cambiado, el Estado no ha dado respuesta a nuestras demandas, sigue la situación de emergencia. Las compañeras trans siguen siendo amenazadas, las compañeras cisgénero siguen siendo violentadas, seguimos en la misma situación frente a ello, hemos calmado el estallido de cierta forma, pero sigue siendo la extorsión una de las amenazas para las compañeras trabajadoras sexuales. Así es. Eh, Hago llamado para que puedan donar, y a la vez quisiera compartirles un video de un encuentro, una reunión de acuerpamiento que tuvimos las organizaciones trans. Entonces, eh, quisiera compartírselo y decirles que la resistencia continúa y que no somos víctimas pasivas, y vamos a seguir buscando cómo apoyar a nuestra población.
Out room 1, and we today have Maud Chinembiri and Eliza Gwenzi. They are from Zimbabwe. Eliza, very nice to see you. Maud, I know you are around, but I can't see your video.
Hi, can you see me now?
Yes. Yes, that's great. Great. Thank you so much. Thanks for joining us today. And so we have a short presentation by Maud and Eliza, and they're going to talk about internal stigma. They're going to talk about their project with young people in Zimbabwe, and then we are going to open it up for some question and answer and clarification. Over to you, Maud and Eliza. Thank you.
Thank you so much. Good afternoon to everyone. Confirm you can hear me loud and clear.
Yes, please.
Yes.
Thank you so much. So my name is Eliza, as mentioned, and with me is Maud Chinembiri, and we are both here to share with you about the work that we are doing with called Wakakosha, a self-stigma intervention to improve self-worth and well-being among young people living with HIV here in Zimbabwe. So we are going to co-present together with Maud. So just next slide, thank you. And so here is a definition that we use here in terms of to help us be clear in when we are dealing with the issues of stigma. So we are saying stigma is when you think negative things about me because I have HIV. And then also discrimination is when you do negative things to me because I'm living with HIV. Whilst internal stigma is when I personally think or say negative things about myself or do negative things to myself because I'm living with HIV. So we are going to concentrate much on the internal stigma. As we go to the next slide, we are here, we see a socio-ecological system where it's talking about the introduction. There is inclusion, acceptance, and belonging. Here we are saying that, so if we believe that we are not good enough, because self-stigma is about what I believe. So if we believe that we are not good enough, it then means we won't feel any worth. And even if anything good is happening to us, we won't feel it. So we are saying here, it all starts with the individual, and then our families, our peers, other community, and other structural levels within our communities then come in as well. So we are saying with self-stigma being moved to self-worth, a person is able to access and adhere to their treatment, and they're able to even participate in other social settings within their context. They're able to participate, seek opportunities once we've dealt with self-stigma, because we are saying as a result of self-stigma, it impacts a person's ability to live positively and limits them from a meaningful becoming a meaningful self-agency, and then also affects their way that they adhere to their treatment and even their access to medication. So we are saying we need to first of all deal with the self so that we are able to be meaningfully participate in the other circles that surround us. Next slide. So I will talk a bit about the interventions that we have here, which is the Wakakosha program. So Wakakosha, meaning I am worth it. This is a unique evidence-based peer-led intervention which seeks to address self-stigma and improve the quality of life for young people. And this Wakakosha self-stigma approach was co-created together with young people. It was also named by the young people who are living with HIV, drawing from their own experiences living with HIV and also living with stigma and shame that surrounds HIV. And this program is integrated into a coexisting Shandiri peer counselors program. And Shandiri is a peer-led intervention. Shandiri connects children, adolescents, and young people to trained, mentored peer counselors who assure to try and help assure health, happiness, and hope for them. And these peer counselors are also young people who are also living with HIV, and they have been trained in the Wakakosha program so that they are able to also have the skills and the techniques to provide support. This program is based on inquiry-based stress reduction, IBSR. My colleague will explain a bit more about it. It is a technique of self-inquiry and includes a 10-day and 16-week workshop series where we have a training of trainers and also ongoing community of practice and an online resource bank. So the Shandiri peer counselors are trained and are then also mentored to also then come in and support their peers to try and address the issues of self-stigma. This program elements include a cognitive-based approach, creativity, where we have the use of music, poetry, writing, as well as drawing. It's got a mindfulness of trainers and an ongoing community of practice with a lot of online resources. And some of these resources, I'm sure you may have access to them as we will put the links into the chat box. And the target group has been adolescents and young people living with HIV, aged between 18 to 24, belonging to diverse and marginalized communities in their diversity. The self-stigma inquiry-based self-reduction has not only been used with Wakakosha, but has also been tried and tested in other interventions with, for example, sex workers, and also in Vietnam with people with TB in Philippines, with those living with obesity in Ireland, and even those people who have been experiencing gender-based violence within Zimbabwe. And so the Wakakosha project seeks to address the issues of self-stigma, improve quality of life through the support that the young people will be given by their peers in a peer approach. I will let Maud take over from here as she shares with us in more depth about the Wakakosha project, what's involved, the modules that are covered, and how we also support the young people. Over to you, Maud.
Hi, everyone. Thank you so much. Please confirm if I'm audible as well.
Yes, we can hear you. Yes, you are.
Okay. Okay, so with my name is Maud Chinembiri, and I'm from Zimbabwe. I'm the project officer for the Wakakosha project with Shandiri and Beyond Stigma. So thank you so much, Eliza, for sharing that amazing presentation about Wakakosha. So with Wakakosha, as you can see, as Eliza alluded earlier, that we also have a concept of art and artistic ways for the young people, because we want the Wakakosha to be exciting for young people. As we are young, we also want to have exciting things for ourselves. So in the Wakakosha program, we have a lot of drawings a lot of graphics like here. As you can see on the far top is a graphic of the modules that we have in the Wakakosha project. On the left hand, on the top is written Wakakosha, and then on the middle is written my body and sex. This is one of our modules that we offer for young people, because young people, they always want to complain about their bodies, and if they are growing up, coming from the adolescent and growing up, so they worry about sex. So they have a lot of thoughts and shame and guiltness about their body. So this is one of the examples. For example, they have so many thoughts, like, I can't satisfy him, pleasure is over for me, I will transfer the disease, I don't deserve to enjoy sex. So we identified these modules according to what they feel and what they have shame on. And then when you look on the left side, you see that we have on every module that we do in the 60-day course, we have these graphics, and then they have to explain what they feel, and then we draw them. So every time when we come, we have what we call check-ins in the day-to-day running of the sessions. So they check in, telling us their emotions, what they are feeling, if they are feeling happy, if they're feeling anxious, warm, or loved in that session, in that moment. So we do with a lot of emotions, because thoughts, they come with emotions. So these emotions, they also drive them to feel a little bit guilty about their HIV status. So here we have also another module on my body and HIV. So we also have a tool that we call the WORK, or IBSR, which is the inquiry-based stress tool. That is the yellow card that we use, which has got 4 questions, which ask them how they feel about a certain situation, or about certain thoughts that they have in that moment. So we just have to ask, like, for example, they say, I don't like my body. And then, for example, for me, I'll say, I don't like my body because I'm slim. And then I'll ask myself, is it true? And then in these sessions, we also deal with meditation. We have breathing sessions where we have to come back to ourselves and compose ourselves. So the Wakakosha also deals with the self, especially when you look at other examples like shame and guilt on the other modules. So we have to ask ourselves, how do you feel if you are shameful? So the Wakakosha program deals with the self mostly, and the shame and the guiltness. And then later on, after we've done these sessions, we always want to have a letter of forgiveness. So we have letters that we write. We have letters that we write to ourselves. We have letters that we also write to other people that infected us with HIV. Thank you. Next slide, please.
Maud, can I think we are running out of time. We have 3 minutes in case people want to ask any questions. So I would also request people to raise their hand if they want to ask any clarification, questions. And if I see a raised hand, then I would stop Maud, but I will let Maud continue at this point in time. Okay, so Maud, continue.
Okay, as Eliza already alluded to, I'm just going to rush in with the research element that we have on Wakakosha. We have a research element because we always want to see what the transformation of the intervention and what is it will do to young people. So there's a lot of transformation with the research that we had. We also realized that after the intervention, many young people had vital new skills, have a sense of purpose, have a sense of worthiness and the self-agency, so that they can also have uptake of services of sexual reproductive health services, self-confidence, entrepreneurship. They realize that they are good at so many things. They also forgive themselves, because there's a lot of shame and guiltness when they have self-stigma. Next slide, please. Okay, in the Wakakosha, we also have a lot of materials that we use. We have the journal for the young people. We have the yellow card that we call the 4 questions and the turnarounds, which is the work of Byron Katie that we use, or the inquiry-based stress reduction tool. So this tool we use it to question our thoughts. Thank you so much. And also we have a nice video in our resources. We are going to share with you our videos, and we love to sing because it's a way of expressing ourselves. So you are going to receive our sending things there underneath. You can also see our songs, our poetry. We love to also involve ourselves. Thank you so much.
Great.
So the
Thank you
resources will be
so
shared
much. Yes, all the resources are there. These slides will be shared with you. We will put some of the resources also in our newsletter, and you should be able to, all of you should be able to get it. So I do see a question here, and I see a question from Peter, who says in South Sudan, due to high stigma index, self-stigma is on rise and killing a number of clients that are limited. What advice would you give to the countries like South Sudan on the path to initiate self-stigma reduction program? So a new country who wants to start a self-stigma program, where should they start? Maureen Eliza?
Okay. Hello? Okay, so we are also reviewing our index, and we are seeing that many countries have a lot of self-stigma. So you are free to also contact us, and then we can see how best we can also do this intervention in your country according to the way you like. And also the global partnership is free for every country. I don't know if you have joined the global partnership for your country. And then we are also going to be rolling out some of the Wakakosha guidelines that we have so far, that we have also rolled in Ghana, and some of the Wakakosha intervention that we have. So you are free to contact us and see how we can move through South Sudan. Thank you.
Thank you so much, Maud. Thanks so much, Maureen Eliza, for such a beautiful presentation. As I said, your slides have a lot of information, and your slides have a lot of resources. And Dottie in them also shared a lot of resources from Global Partnerships. So I would urge everybody to go and look at those resources. And for now, we have to close, and we'll have to go back to the main room. So thank you again, Eliza and Maud, and thank you everybody who joined this room. Thanks. Bye-bye, and see you in the main room.
Thank you.
Well, good morning, evening, afternoon, everyone. So I'll be talking about how the partnership between the government and K-pop organizations in Jamaica were able to create a space where we were able to do a series of activities, but focusing specifically on capacity building activities within Jamaica to create an enabling environment, specifically for LGBTQ plus persons, but more broadly for K-pops generally. So next slide. Right. So in terms of, when this started, so around 2011 to 2012, JFLAG, which is the organization I'm with, we implemented a pilot program where we trained 20 healthcare workers in partnership with the Ministry of Health and Wellness, using the initial curriculum that we had developed to address the realities facing LGBTQ plus persons. Then shortly thereafter, in 2013, funding was secured, I think with Vive Healthcare, and we were able to implement a full project that was more wide-scale, taking some of the lessons from that initial pilot program. We engaged the National Family Planning Board, which is an agency within the Ministry of Health, and worked with them to do mobilization of healthcare workers across the island in Jamaica. In 2014, there was a standards and regulations unit within the Ministry of Health that we also additionally engaged, and they came on board as a part of the project to promote what exists within the Ministry of Health in Jamaica, which is what we call, they have a client complaint mechanism that they use. And so we put that in as part of the program. And then what ended up happening is that between 2013 and 2018, we ended up in partnership with the Ministry of Health training over 1,000 healthcare workers, focusing both on the medical staff, doctors and nurses, as well as frontline staff. So that includes your porters, your filing clerks, and a few security guards as well. Additionally, during that period, we would have trained service users, and that involved us as an organization going in to health facilities, clinics all over the island, working with the departments, say that differently, working with the human, not resources, but the PR department. I'm spacing on the word right now. But working in the department that deals with public relations in the hospitals to be able to engage community members that access the services so that we can also raise the issue of the experiences of LGBTQ plus persons when they access services within the health facility. And so as a final component of that project since 2019, as an organization, we've been, once again, working with health facilities to do mystery shopping exercises as a way of assessing what the actual experiences are on the ground of LGBT persons when they access services. And so that involves us reaching out to these, to the different facilities, letting them know that the mystery shopping will happen, and then going in anonymously and checking what the prevention services are like for members of our community, as well as their general health services, and then doing a comparative analysis to see what the experiences are. Next slide. So in terms of, the specifics of what happened, it started out with that kind of early engagement of National Family Planning Board and the Ministry of Health and Wellness as a way of underscoring the importance of doing this work. And then they, being a government agency, arranged the meetings with the regional health authorities. And we have 4 regions in Jamaica. And they arranged the meetings. And then we both met with the regional health authorities to discuss what the program would entail, why it is important, and how it critically would kind of impact the prevalence rate within the key population of men who have sex with men, as well as trans persons in Jamaica. Then we worked with them to compile a list of participants. So we would work with each regional health authority, who would then mobilize the participants at the site level to participate in the training. After that, then we kind of would have met with persons in select facilities to do the training program, particularly as far as the service users component is concerned. We did the training, we did the sessions, and we also did site visits as part of the training, and I'll go into depth into what the training itself entailed. And then we got feedback at the end of the 6-week training program, or well, it's a 6-month program, but it's stretched. It's really 6 days of core training stretched over a period. And then we would have gone back and gotten feedback about what the experiences were in terms of the training and how they were able to incorporate lessons learned into their everyday practices. Next slide. So in terms of what the program in actuality looked like, so it starts with a 3-day workshop, and it's a residential training where we remove the healthcare workers from their space to usually a hotel where we're able to focus on the actual training itself. And then after that 3 days of training, we allowed each participant to kind of select a topic within the modules to then go back and present at their health facility where they worked. They would then go and do that, present to their co-workers, some with more success than others. And then there would be a follow-up 2-day workshop that we did where they would come back and share what their experiences were and what their challenges were, trying to raise issues around, differentiated service delivery, gender and sexual diversity with their co-workers. And then while that was happening, we were having the concurrent service user sensitizations, which meant going to individual sites and working with the team there to be able to mobilize community members, to hear about the experiences of the community, to hear about human rights, to hear about the client complaint mechanism and how they can rate and how they can make health spaces more comfortable for vulnerable groups. And so after all of that happens, we waited 3 to 4 months to do site visits. So we would go and see how things were. We were also developing communication materials, posters, to see if they were able to mount those posters within the facility, to see if some facilities did have like audiovisual equipment, so they could like showcase some short videos that we had promoting tolerance and inclusion, and you know, addressing and promoting the client complaint mechanism. So those were the subject of the site visits. A critical component that kind of became a part of the program throughout the many years of its iterations is that we began to include members of our community as part of the training program. And what that means is that we would train LGBTQ+ persons to be able to tell their stories, to be able to talk about their experiences. And within the 3-day workshop, we would have a panel discussion where they share those experiences. And that would be the critical juncture for a lot of the healthcare workers and frontline workers, where they were able to address some of the myths that they had about the community, their perceptions, and it really shifted the tone. And then after the program was done, we did a final assessment, and we're now in our mystery shopping phase. Next slide. So to get an idea of the content, and I know I kind of rushed in because of the time, we are an LGBT-focused organization in Jamaica. I didn't do that introduction. So what the content looked at is why provide the services. So looking at the background of what the situation is for LGBT people in Jamaica, specifically as it relates to the prevalence rates to HIV. We talked about values, how people were able to, people's sense of their own values and how that impacted their work. We did standard gender and sexual diversity training, so they understood, you know, sexual orientation, gender identity, and so on. Looked at what it would mean to do trans-inclusive healthcare, the very basics of human rights and how it impacted their work, sexual health needs of the community, and the component around the cultural and social expectations of LGBT people. That is where we had the panel discussions. And then we went into differentiated service delivery. What would it mean to give services to the community? What their risks were, how you communicate verbally and non-verbally to members of the community to address the fact that there is that concern around stigma, the difference between stigma and discrimination and how it manifests, the experiences of the community with mental health, anxiety, and depression, and how to do motivational interviewing. Next slide. So, and it was so these are some examples of our methodologies. You know, we have panel discussions, plenaries, interactive games, simulations, a lot of video presentations, and follow-up reporting. So it wasn't just the kind of standard PowerPoint presentation. It was really immersing the healthcare workers into the experiences as best as they can. And Jamaicans are very dramatic people, so they love simulations. And of course, the site visits. Going through the next slide, because I see the time. Next slide. And so critically, what some of the impact was is that in a recent survey conducted by UNDP, of all of the spaces where LGBT people continue to report experiencing discrimination, healthcare spaces had the lowest level of reports. So only 8.4% of respondents said they experienced discrimination there, when on average, most people, the average in other spaces was 33.3%. And this looks at in the workplace, malls, restaurants, in the neighborhood, in schools, in many different spaces. So what we're seeing is that focused attention led to a drop within the health spaces. And the mystery shopping, exercises that we've been doing have continuously shown that LGBT persons are experiencing better treatment in health facilities. However, there's still some issues as far as trans persons are concerned. There's still some difficulties in using the correct language and terms as far as engaging the trans community. And so the last slide, we can go to the last one, is some of the indirect impact. So we've a stronger relationship with the Ministry of Health. We've had, high-level ministry officials at our events speaking on LGBT issues, supporting our work around training mental health practitioners. So we took that learning and we put it into how do we train psychologists and psychiatrists. We've had a minister supporting calls for decriminalization. We're consistently represented on many subcommittees and panel discussions and any research activity that the ministry is doing. And then we've had a health fair where we have government participation. So the partnership is alive and well. And I think I want to kind of wrap this up quickly and allow what little time we have for questions by saying that the key lesson here is that without the partnership, much of this would not have been possible. So I am now open for questions and I don't have a lot of time.
Thank you so much, Glenn. I mean, that was really inspiring. That was amazing. We hope that we could see such a great work across all of the settings now that we know it works in the health facilities. So what you've done is amazing. I'm trying to look at the chat and I'm also cognizant of the fact that we have 5 minutes, less than 5. So please, anybody who would like to come with questions, with comments, please go ahead. Lessons learned. I think Glenn has really captured it very well. So I'm not seeing any hands, but maybe Glenn, do you want to come and tell us maybe a bit of how this has been affecting the community themselves? I mean, how do they feel about it themselves? What's next? Yeah.
I mean, there's a lot that's next. So the truth is, as an organization, what we've done is we've taken the learnings from this particular training and we put it into other areas. We've done it with the youth development area. We're doing it with mental health. We've done it with mental health. We just did some research around the disproportionate impact of non-communicable diseases on our community to see how we can begin to roll that out. I didn't mention a lot of like the research and the curriculum development that kind of led to us doing this in the interest of time. But that was a part of that work. We did a lot of assessing what the experiences of the community was. And so what we're doing now is promoting amongst the community what the available services are and seeing how best we can extend that to other areas and encouraging community members not only to use the resources, but where they have challenges to let us know. So because that partnership exists, we have a direct through line to say, hey, this is where you need to work on.
Excellent. Thank you, Glenn. And I feel like what you're saying is like you said, it's the commitment of the country when joining the global partnership. And Jamaica, I have to say, has been one of the countries that were championing that work, and we're seeing how much the collaboration with the partners is. So really very commendable. I don't know if we have time, but if you want to also speak about the partnerships across in the country itself, how closely the communities have been working together across other networks of population and people living with HIV, because this is really crucial as well.
Thank you so much for sharing this. And I think the video can be shared through a link with everyone. As you may have noted, we have taken the full time for hearing great experiences here in the main room from Peru, and I'm sure you had good discussions as well in the other sessions. If there are open questions to the presenters from those country experiences, please feel free to put them in the chat, because there was limited time for discussion. Without further ado, I think we can go from these experiences into the takeaways from this session. So what can really make a difference and what can have an impact in reducing stigma experienced by key populations at scale, at country level? And we'll have reflections from different speakers, starting with Yuri Klimasevsky from the Ministry of Health in the Republic of Moldova. So Yuri will be speaking in Russian, so please switch to the translation that you need. Over to you, Yuri, in Chisinau.
Здравствуйте всем. Я очень внимательно слушал все презентации, очень интересный опыт, очень интересная информация. Значит, я очень коротко представлю что я подготовил. Значит, все, что касается прав человека, это, да, и дискриминация, но это должно иметь два таких компонента, да. Это первое, это правовая база со стороны государства, Министерства здравоохранения и так далее, ну, в зависимости от уровня, да. И второе, это мониторинг. Значит, вот в первой рубрике я хочу сказать, что у нас принят закон о равенстве, который который дает право любому человеку обратиться и защитить свои права, вне зависимости от того, где или по какой причине ему это ущемили эти права. Да? И есть даже и механизм внедрения. Да? Есть комитет по равенству, куда любой человек, который считает, что его права были ущемлены в любой сфере, он может подать заявление, и его жалобу рассмотрят. У нас есть жалобы, которые были поданы представителями МСМ, да, мужчин, занимающихся с мужчинами, да, и одна из них даже была выиграна. Значит, потом есть закон о ВИЧ-СПИДе, который тоже очень, как бы говорится, черным по белому написано, что любая дискриминация связана с болезнью ВИЧ исключена и не должна быть допущена, и не только к ВИЧ-инфицированным, но и ко всем тем, кто имеет отношение к ВИЧ. Да? И второе – это мониторинг. Значит, мониторинг, вот у нас есть установлено такое, значит, community lead monitoring, это мониторинг представителями сообщества, потому что они заинтересованы в этом, и естественно, что этот мониторинг очень качественный, да, это и React, и другие моменты, которые мы разработали. Значит, все это мониторизируется, и каждый случай ущемления прав ВИЧ-инфицированного или члена семьи ВИЧ-инфицированного, значит, рассматривается и доводится до как бы логического конца, да, чем это закончилось. И мы считаем, что это очень такая хорошая модель, когда и на законодательном уровне было сделано, то есть принято законы, и мониторинг качественный, тем более от сообщества. Спасибо.
Спасибо большое. And really great insights on applying non-discrimination laws, and in addition, also community-led monitoring. And so with that, we can move to our next speaker, Arya Shabazpur from Impact, please.
Can you guys see? Can you hear me? Can everyone see and hear me?
We can hear you, Arya. Please, over to you.
Good morning, good afternoon, and good evening to all the colleagues. Thank you very much for this opportunity for me to share a few insights. I've listened to all the colleagues talking about different approaches to addressing stigma, and it is very enlightening and eye-opening. And I thought maybe by sharing a few insights, I can give you the perspective of impact and a few words from the key population. When we talk about stigma, it is very important to understand that we cannot begin to address the stigma without acknowledging that the stigma is constructed. And nearly 7 countries around the world criminalize same-sex behaviors. And the laws in Ghana and Uganda and Russia strive to make all aspects of the LGBTQ people and their lives criminal. Homophobic and transphobic policies and attitudes foster violence and discrimination. And as a result, when we talk about addressing stigma in key populations, at first we need to recognize the bigger issue that our community is facing around the world, and that is the the basic right to exist. And in the present social and psychological, social and political climate, where trans individuals are being banned from public places like parks in Iran, or when we see new anti-LGBT legislations coming from Ghana and Africa, it is very difficult to address stigma when their whole existence is under attack. Pushes the population to reside in hiding in fear of their safety, and consequently creates a more hostile environment. And we cannot begin to address stigma in its full, let's say, capacity. I remember personally, as a gay man living in Iran, the paralyzing fear of discovery, the paralyzing fear of stigma, it stops you from reaching, and it stops you from exploring, it stops you from participating in the society. And when we talk about constructed, when we say stigma is constructed, what does that even mean? When we talk about stigma in a context of individuals, it is very easy to narrow it down and to say one person is facing stigma. What can we do to stop that from happening? But I urge you to look at the bigger picture and to wider your perspective as why the stigma, how does the stigma is structured, and is structured by who? Usually when we talk about stigma is structured by governments, by religion, by culture, by institutions. And there are two ways of looking at stigma: from the bottoms up, which is that individuals, their experiences, and it's about the top down, like what can we do to change the structure as a whole that ensures that these individuals will not be subjected to the same things when we move forward. We say constructed, the perspective needs to change. And the way forward, I suggest usually what matters is visibility, representation, because when these individuals that are all facing the same stigma, then they connect and they realize they're all facing the same thing. And this creates the community. When there's representation, there's visibility, there's community, this empowers the population to take action, to be more proactive, to participate, and it as a result reduce the stigma. When we come to reducing stigma in any form of setting, it can be humanitarian program, projects, preventions, inclusion. The first step would be to educate and advocate for the rights of the key population, because education and accountability ensures LGBTQI individuals are safe when they're accessing healthcare or HIV services, and accountability for those who perpetrate discrimination. So when we talk about the population, when we talk about their rights, it's important to mention that at the climate that there are a lot of investments in governments and policies that criminalize the population, there should be equally and comparably investments in our community, because the investments means affirmation of the LGBTQI lives. By encouraging and empowering the population itself to take control of the narratives and actively participate in programs, where first of all, it will ensure the successful implementation of these stigma reduction programs. And secondly, it will provide an inclusive atmosphere that ensures the population's engagement and consequently success of the stigma reduction campaigns. So providing safe spaces for LGBT people, not just in the regards to HIV treatments or prevention, but ensuring that they actively participate in their community and have a good quality of life. I don't want to take more time of the colleagues. I thank you very much for this opportunity, and I hope these insights were useful. Thank you.
Thank you so much. Indeed, very useful practical insights on stigma reduction campaigns from a community perspective. Over to you, Kent. Kent Clindera is with USAID, a major funder in the HIV response, for additional reflections.
Thanks, Clemens, and really happy to be with everyone today. This was wonderful. Thank you for putting this together. I really appreciated the diversity. I heard several things, and I think I always start when I talk about stigma, it's painful 30 years into this epidemic. We're still struggling with the stigma, but here we are. And especially as we look at CoPs, something USAID is very keen and has been working on for a long time. I think I heard a few things that I want to reflect. First, this whole concept of internalized stigma, especially with CoPs, of internalized homophobia, transphobia, sex workers. We really need to invest more in building communities and helping folks be themselves. And it's a key piece USAID PEPFAR works on. So that's a key thing I heard, and we need to continue it. I also heard U equals U, and I think we finally have some data. U equals U actually is a stigma reduction tool. And so it's something, just left our big Asia regional meeting with PEPFAR, where U equals U was being mentioned in every country. And I think it's something CoP should take on and something we should be promoting. I appreciated the focus on KP-led CSOs and their role and UNAID's goals around the 30-80-60% of programming that's delivered by women and K-pop-led. It's a key piece. I'm actually here in Botswana, actually focused on this right now about how we can scale up, directly fund some K-led CSOs here. And then finally, I think, it's about hearts and minds. And I think I asked a question about legal reform and how we're measuring that. But I think it's very much about, impacting hearts and minds. And when I work with CoPs and I walk, I listened to, I was in Glenroy's breakout, and just the work done with government in Jamaica, that's how it's going to change. And so I appreciate all the work that KP leaders are doing, how we can, UNAID's supporting this. It's a very impressive show today. So thank you.
Thank you so much, Kent. And yeah, important reflections and great work happening in terms of also taking the community-led, and in this case, key population-led response forward in addressing stigma, but also prevention and other elements of the response. I will not try to summarize because we have gone beyond our time, but clearly the important next steps. This is a space of collaboration between the Prevention Coalition and the prevention implementers, human rights activists, and community-led organizations. And with all these ideas that we have heard today at country level, there's actually an opportunity to come together in a similar way. People working on scale programs, prevention programs, people working on advocacy come together and see how these actions and these evidence-based interventions that we've seen in the guidelines can be integrated into scaled national HIV responses so that we reach actually a significant or large enough number in line with our global targets of key populations and key populations in leading roles in the response to address stigma as part of the HIV prevention and broader HIV response programs. With that, I wish you a great rest of the day and look forward to future discussions. And next session of the Key Population Community of Practice will be held on a related topic, enabling laws for HIV prevention in relation to key populations. And that session will happen around the AIDS conference in Munich, and be another webinar that you can join, or if you're in Munich, you might even want to drop in the actual session. So thanks so much, and looking forward to continue engaging.
Thanks so much, everyone.